Hello, and welcome to our conference this evening. I'm very happy to have you with us. My name is Kate Bush, and I'm the coordinator for programs and services with the ALS Society of Quebec. I'm very pleased to be able to present Ann-Marie Léporé, who is our conference speaker this evening. Ann-Marie is an occupational therapist. She is a graduate of McGill University with over 30 years of experience in the health and social services network. The first half of her career was spent in hospitals at the Neuro and the Royal Vic, and the second half in home care at the CLSC de Pierrefonds. Even if the clientele followed is varied, it is mainly those with degenerative neurological conditions, such as MS, ALS, Parkinson's disease, dementia, etc. Welcome, Anne-Marie, and it's yours.
Thank you so much, Kate. So today I will be talking about what to expect once you register at the CLSC. So it's usually, obviously, when someone is newly diagnosed with ALS, then the next step is to refer somebody to the CLSC. So let me see if this works. Perfect. So the presentation is bilingual because I've done it in French and now it's in English. So it both works very well. So the entry point at the CLSC. So at first, there's the initial, obviously, request reception. And I just realized it's a typo in initial, so I can modify it after. It can come from either your specialized clinic where you're being followed. It can come from a family doctor. It can come from a rehab center, but usually it starts where you've been diagnosed with ALS, um, and it's sent to the CLSC. Now they know in their system where to send it to, which CLSC. If you do not know which CLSC you're part of, which territory of the CLSC, I've added the website of how to choose your CLSC. So you'll be able to press on that, and I'll try it to make sure that it works. I'm changing my screen here. There we go. And you can find with the postal code and within 5 kilometers, 10 usually the closest to your home. And if you write the province, you'll be able to find out which CLSC it is. And it's something usually that the whoever's referring you to the CLSC should know. Otherwise, with the repertoire, you can call various CLSCs closest to you, ask, is this the territory for which will be following me? So once it's received to the CLSC, it goes through usually, again, I'm going generally speaking. Sometimes the organization of each CLSC varies. So it's really generally to give you an idea. So once the request is made to central intake, so it takes all the requests from the outside, then it gets after that directed to the home care service. And then from the home care service, whoever's in charge of looking at all the requests coming in, they get to prioritize the request. Generally speaking, again, because each CLSC could be different, the diagnosis of ALS will be prioritized. Okay, I can talk from my own experience from CLSC Pierrefonds and CLSC Lac Saint-Louis, which is the West Island part of the island. They are prioritized, the diagnosis. So just to let you know. And then, and because, like I said, the service offer may vary from one CLSC to another, you really have to inquire, specifically to your own CLSC, what type of services or the priority or where you are on the wait list. Now, once your file is assigned, okay, to somebody in home care, okay, you'll be assigned to a case manager, somebody, a professional or a personnel member who's going to be really in charge of your entire file within the community, within the different resources. And that's usually either a social worker technician or a social worker, an occupational therapist. It's not as often that it's a nurse, so I didn't put it there, but that's usually the typical, case manager that will be assigned to you. Um, and then, so what they do is they get in contact with you. They make an appointment for the first assessment. Um, it's up to you to decide if you're ready for a first assessment. Um, Once the file is referred to the CLSC, everybody is at a different, let's say, level of functioning. Everybody's at different stages of the process of um, not understanding the disease, but at dealing with what the news is about. So it's up to you to decide if you're ready or not for an assessment. I do suggest that the earlier the better. It's not because you're getting assessed that you'll have to do anything else. It doesn't mean that you'll have to start going with the plan that is suggested or whatnot, but at least you've had an idea of where you are functionally, where you are in the system, because the system is quite big. There's sometimes delays, and it gives you an idea, so then you can make an informed decision. So once it's accepted to have the initial global assessment, it basically is going to be the assessment. It entails not only the participation of the person with ALS, but also with the caregiver or a close friend or something that's very dear to them, because we all work as a team in this manner. Um, so we really work together like that. In terms of the assessment that's being assessed, it's actually the OCCI, which is Outils de cheminement clinique informatisé. I didn't know if there was actually a term in English. So that is the computerized clinical pathways tool, where it's quite a long, detailed assessment that is being done or asked of you. So it asks the aspect of psychosocial, anything medically, um, all your functional aspect, how you do your things everyday life, your physical aspect, psychological, all your resources. And then after that, so once that's all entered in it's a computer, so people usually come with their laptop or they might write notes. And then once the data is entered, then there's actually problems that come up to help out identify the problems. And then there's also identifying the expectations. So once that's done, it could be 1 or 2 visits, sometimes 3, depending on um, the tolerance level, the fatigue level, and whatnot. So once that's entered, then we're talking about an intervention plan. And this is a joint intervention plan between the professional and the person with ALS and the caregiver. It's again according to the needs. So what came out as problems needs? What are the expectation? What is doable within the healthcare system? So that way the person with ALS and or the caregiver can make an informed decision in terms of where do we go from there. So that's basically the initial assessment. The case manager, what does it do? The case manager is the contact person in the file. So it has an overview of the situation. So when I'm saying the file is within the entire healthcare system, okay, it makes, or he or she makes, the internal and external referrals. So internal, whether it be to any other professionals within the CLSC or home care services, and external referrals would be to various resources, various, if there needs to be something for a rehab center, that sort of thing. And it also receives all the external and internal information from all the parties involved. So that way it has an overview of the situation. And like I said, it also makes the home care services request. So if we go more specifically in terms of the various professionals that could be part of this interdisciplinary team or multidisciplinary team at the CLSC, because we're many professionals that can be involved in the file. We'll start with a social worker. So basically, the social worker will be doing a psychosocial assessment. So anything from how someone's feeling, type of resources, support they have, what the expectations, the goals, and again, initially when I talked about a joint intervention plan, joint assessment, it refers to all these professionals. You know, it's a team effort. Everybody's involved in that. Different examples of interventions that could be done. Um, Listening and support, counseling, of course. And again, it varies from CLSC to CLSC. You have to ask. They can make community and financial resources. Sometimes the social worker knows a bit more about the community resources, the financial resources, than a case manager. So together as a team, we all work together to make the requests. Financial resources could be either from income tax credit, um, to anything that they're aware of. And then if you look at, I put this here, the conference from Louise Boivin, who is actually, if my memory serves me correctly, is a social worker, but also she talks about, um, what is it that you need in terms of uh, psychosocial support and follow up in terms of it's in French only. I didn't find it in English, but it's good to listen to in terms of support for people either with ALS, or it can also be in terms of um, caregivers, but it's mostly person with ALS. So that's a good starting point. Um, Again, the information here is general. Feel free to go as much as you want or as little as you want, depending on your tolerance level, where you're at in all this process. The next professional is a physical therapist. So they will be assessing the physical aspect. So the balance, the strength, the range of motion, um, and usually the professionals will be referred to from the case manager as needed. Sometimes all of them are needed initially. Sometimes it takes a while, depending on the level of the disease or the readiness of the person with the disease, which is fine too. A couple of examples of interventions you have: prescribing or recommending exercises. Depending on the level, it could be different types of exercise. It could be light to moderate. That's been, and actually we just at the ALS motor neuron disease allied professional forum last week, and it seems to be proven that light to moderate exercises seem to be doing okay for people with light to moderate ALS symptoms. So again, it depends. Speak to your physical therapist about that, and the doctor, obviously. They'll look on how you're doing the stairs, if there's stairs in your environment. Any types of walking aids, whether it be canes, either a simple cane, a quad cane, a walker. And also they'll look at different transfers that you do around your house. So from a chair, they'll look into that, from the sofa sometimes. And that sometimes is jointly with the occupational therapist. The dietitian, nutritionist, obviously they'll do the nutritional assessment. So what you eat, what you take, the type of ingredients that you take, the type of consistency of the food and the liquid that you ingest. And one thing to remember with ALS is that the disease itself will be using a lot of calories, will burn a lot of calories even at rest, just because of the nature of the disease. So when it's time for the nutritional assessment, although one might have a very balanced diet pre-diagnosis of ALS, once it's established, they have to modify their eating intake to um, um, compensate for the loss of calories. So you have to eat a lot more calories than your normal balanced diet. So that's one thing that you'll look at, or you'll look at the calories balance. Make sure that it's equal. So what you burn is equal to what you take in. There'll be obviously some weight follow-up. There might be recommendations of supplements, various supplements. There might be an assessment of dysphagia, which is difficulty swallowing, and try and see how to compensate for that. And that is usually done by the nutritionist and also in conjunction with the occupational therapist. We're usually a team. That's what we do at CLSC Pierrefonds. So it either be a first assessment or a follow-up of what has been assessed already in the specialized clinic. And then if there's any alternative methods, follow-up they'll be in charge. They'll be able to follow that at home. And also there is another presentation on the ALS website, SLA Quebec SLA ALS website, where it talks about optimizing the nutrition um, in an update, so that you can listen to. Okay, next slide. No questions so far. That's good. Perfect. Physician now. We have obviously the physician will do the medical assessment. And in terms of intervention, we have the vital signs it might take. They'll look at the medication, prescribed medication, obviously. And also, if there's any type of medical information you're looking for that you might not get with the clinic, then or your family doctor, that's something that they can look into. It's usually they don't get involved right away because it's people are usually followed in a specialized clinic. They're able to get there and back. As with time goes by, it gets more and more difficult sometimes. So then that's when the home care physician will be involved, because we have to remember that home care is usually for people who have difficulty going out, except obviously for social worker and occupational therapist. It can help right away, even if somebody's still able to go in and out of their house or their homes. Um, Early intervention is beneficial to that effect. A nurse will go with the health assessment. Again, she can be involved in the vital signs, just like the physician. In terms of elimination, can assess, how's the voiding, how's the elimination, bowel movement, urinary elimination, recommend certain things. If there's any need for dressing, they're the one that's going to be involved with that. And obviously following up on any medication, whether it be side effects, communicate with the doctor, or making sure that it's followed properly and things like that. Then you have the Health and Social Services Auxiliary. Okay, that team member is there to either assist or provide the home care services in a safe manner. So that would be, and I'm gonna just a second, I'm gonna take a sip of water. Thank you. So that would be, those are the people that go in from the CLSC to help out with home care assessment. We often call them PABs, or préposés aux bénéficiaires. That's more in the hospital setting. So at home it's the auxiliary, but it's the same thing. They have proper training. They know how to do the tasks. And in terms of a safe manner, it has to still be a safe environment for the worker and also for the user. Um, so different types of service examples. We talk about, the hygiene, dressing, grooming. It could be meal preparation, could be cooking, laundry. Again, you have to ask, each CLSC varies in terms of the service offer. So you have to ask your case manager. And then also Bill 90, which is medication, supervision and or administration. So, and certain invasive care. So with the or under the supervision of and the teaching of a nurse, an auxiliary can go and provide certain care according to Bill 90. And then, of course, they are like so essential because they're the eyes and the ears in the home to see how things are going, and they'll report information to the case manager, or it could be directly to the professional, which the problem is related to, whether it be an OT, a physio, or a social worker. Speaking of the occupational therapist, which is my profession, so what do? We assess the functional status. And in terms of functional status, what we mean by that is activities of daily living and instrumental activities of daily living, leisure and work. So ADL, it's anything that's the basic care, grooming, hygiene, dressing, wiping oneself. Instrumental IADL or instrumental ADL or IADL are all the cooking, the cleaning, the laundry, the finances and things like that. Leisure and work are pretty self-explanatory. So we assess that. And once that's done, then we also go obviously to the home assessment. We do a home assessment because we're home, we're into your house. Um, it's not as easy as one would think to um, assess or be or make recommendations, let's say, to somebody's house, because it is your house. So you're in charge of your house. We can't force you to do anything. You're in control, but we still would need, or we still like to do the home assessment to be able to give the person the full and complete overview of what the problems could be or are, and how we can help. And then the person and the caregiver can make an informed decision as to how to go about that. Okay, perfect. So what do we look at? We looked at the access to the house, going in. How is that? We look also inside in every room. Is there any stairs? Maybe there's some rooms that one does not go to because habitual doesn't go. So then we don't need to look into that. But we usually look at every room, especially the most important ones, the stairs, and we kind of have an idea. Um, Different types of examples that we might have. Okay, we have technical aids that we can recommend, which is for ADL, let's say, it would be any type of feeding or drinking aid, whether it be a cup, a spoon, a bowl, dressing, a sock aid. That could be one of the things. Hygiene, long handle brush, grooming, anything to do with shaving or makeup. So there's so many technical aids out there that for every difficulty one has in doing a certain task, there is something there to compensate. Okay. And the reason why I'm a big believer in technical aids is that it still maintains autonomy for the person who requires a technical aid without putting uh, an overburden on the caregiver. So it's win-win that way. In terms of transfers, I'm going to go to the other. Did I put anything for transfers? I'm so sorry. Transfers. I did not put anything in English, but we talk about the bed, a chair, the sofa, whether it be the bathtub or the shower, toilet, or a vehicle. So perfect. I will add that too. In terms of IADL, so we're talking about cooking, medication, taking, whatever. So cooking, again, a gamut of adaptations possible. Whether it be something to be able to use to open a container or cook, medication taking, reminders on how to take medication, there's pills, there's all kinds of things possible. We're looking also at energy conservation. If throughout the day someone becomes tired easily, there is, yes, possibility of pushing through and doing some mild exercises, and that's okay. But if it's really fatigue and the energy conservation then comes into play to make sure that one can pace themselves throughout the day to be able to do everything. Home adaptations, we're involved in either small adaptations, easy adaptations, provided either through the CLSC or the government, or bigger home adaptations with the home adaptation program from the SHQ, so Société d'Habitation du Québec, where it could be a total, either access to the house or a bathroom adaptation. And for that, you can look into the website of the Société d'Habitation du Québec, SHQ. There's an English side and see what's possible. But again, speak with your case manager. And if you have your OT in your file, speak with your OT. There's different ways of going about a home adaptation now. We will be there to fill out, if you have one in your area, transport form, adapted transport, parking sticker form, and we're involved in the dysphagia assessment also in certain areas, with the nutritionist. So give me another second. Okay, sorry about that. There's also, if you want, a taking care video series where it's on the ALS, Quebec ALS website. And by clicking that, you'll see. Okay. It's something that the ALS Society, myself, and Miguel, we were very lucky to go to the Steinberg Center for Simulation Interacting Learning. We did this 5 videos of taking care. So if you want, at your leisure, whenever you're ready, you can look at the videos, whether it be the introductory segment of home safety, the general principle of home education with ALS, or specific rooms, kitchen, bedroom, or bathroom. So it's in both French and English. This one is English, so you're more than welcome to do that. And it'll give you an idea of what to ask your occupational therapist, your case manager. So that's basically the reason why I'm putting this. It's general information, but to give you a clue on what is out there, what can you ask your therapist, so that way you'll be able to get the proper answer. And if they don't know, then it's okay, because not everybody knows everything, but at least they can actually go get the right information, the proper information. In terms of resources, besides what's in the CLSC, there's also resources outside the CLSC. I put them there because a lot of them would be referred from the CLSC, so you would be referred from the CLSC to these resources. Other ones are more of individual, or you might just want to research on your own. On the internet, there's tons of resources or information that you might want to, also check out on your own whenever you're ready. So we have obviously the ALS Society. That's the first and foremost, I find, resource, because from there it's a point of entry to getting either emails about activities, resources, but also you have access to psychosocial support, access to any type of financial aid for some programs and whatnot. So this is really and that's free. You just have to be, registered as a member. If it's not already done by the specialized clinic, then your case manager would be able to do that from the CLSC. Of course, you have the CLSC resources, and when I put that there is not only is there the resources from the professionals and the home care services, but sometimes there's foundations for the last resort in terms of getting equipment or any type of funding. The municipalities actually have more and more programs for people either with disability, with financial problems, whatnot. So please look into the website of your own municipality. Community, there's more and more resources too. Sometimes, they might be limited for X reason, but there is, like I'm thinking about the West Island, there's a West Island Community Resource Center where all the resources are there. So you might have something like this in your community. Provincial and, oh, I see that federal too. Oh my gosh, I did. Okay, I'm gonna have to correct that before it goes on the website. Correct all the typos. Sorry about that. Provincial, whether it be income tax credits, same thing with federal. It could be various things, but the caregiver, whatnot. So there is some type of financial resources there for the provincial and the federal. So, good things to remember. Okay. It's important, I think it's important to participate and ask the questions and be proactive and involved in your file at every level while respecting your tolerance or your limits. Like how much are you able to know? How much do you want to know at the time that you're there, in the present? It might change, it might evolve, it might um, change, it might evolve with time, but I think it's important to be proactive and be involved. The reason why I'm saying that is with my 30 years of experience, we know that things don't get any easier and faster. The healthcare system is quite slow. There's a lot of shortage of personnel. The material is not as readily available, so there are long delays in the system. So just be aware of that. It's okay to not be ready to do something, not yet there at this stage. But unfortunately, if and when you're ready to do whatever, in terms of recommendation, following whatever has been said, there might be a delay once you say, yes, I'm ready in getting something. Okay, so it's always balancing that. You do have a right to decide and to refuse whatever has been recommended, when we go and see you. It's your home. Um, as long as your decision is an informed one, so you've been told and you've asked, what are the pros of this specific situation? What are the cons of this specific situation? And what are the consequences if I delay or if I'm not ready? So once that's said to you, then you can make an informed decision knowing, okay, I'm still going to wait, or knowing that let's put in the request and then, at least that will be, the wheels will be in motion then, And the last thing that I wanted to say is that the team itself, okay, it's not only the CLSC personnel, the workers, but it also includes the person with ALS and the caregiver. Together, we're a team. Obviously, I'm only talking about the CLSC level. That also includes everybody outside that the CLSC, but within the CLSC, we can't work, the workers, we can't work alone. We need the person with ALS, and most often than not, they also need their caregiver. So we can work together as a team to make sure that um, the future is as planned and as well as it can be, let's say. And that's it.
That's fabulous. Thank you very much, Anne-Marie. It was very informative.
You're welcome.
Thank you. So very much enjoyed hearing